Welcome to The Benefit Whisperer, the show where we pull back the curtain on what's really driving your healthcare costs and what you can do to stop feeding a system that's rigged against you. I'm Ralph Weber, and today we're talking about something every employer needs to know: the hidden rules in your healthcare contracts that quietly drain millions from your businesses while carriers, PBMs, and hospital systems keep you locked in the dark. I'm joined today by my friend Dave Chase, founder of Health Rosetta and a national leader in helping employers break this cycle and rebuild health plans that actually work for people and for budgets. Dave, thanks for being here today. Can you tell the listeners a little bit about yourself?
Sure. I mean, I have a background in healthcare, but really on the technology side. And, but what pulled me over into the health plan side was something that happens far too often. I had a friend that got a wrong cancer diagnosis. That happens like 1 out of 5 times.
Wow.
And of course, that led to the wrong treatment plan and the ultimately crushing her physically, financially, emotionally, leaving behind a 10-year-old daughter as a single mom. And it was brutal to see. And it was really a system failure. It wasn't like there was a bad doc or something like that. And that's what brought me into this arena. Is, I'm one who, I think I was raised well. My parents said, if you see something wrong, you don't do something about it, you're complicit. Right. And so it really put me on a quest to understand. And as you mentioned, these contracts, like what could be more boring than contracts, right, in healthcare?
Yeah.
But I did find in that journey that there's no accidents in the many dysfunctions that exist in healthcare. They're all in those contracts. And
absolutely,
they're, and the really underestimated role in our economy and our healthcare system specifically are these benefit brokers, benefit advisors. Like they are the ones who bring in health plans for 54% of Americans. We're talking about 180 million people or so.
Wow.
And the best of them are incredible. That's who we work with.
Yes.
Unfortunately, as you alluded to, there's a lot of perverse incentives, and frankly, the worse job they do from the perspective of an employer or an individual, the more money they make. And so that's got to change.
Absolutely. Yeah, I couldn't agree more. I love that you're in this because of a personal passion. I can't think of a better reason. A lot of people aren't. In my first episode, I'm not sure if you had a chance to listen to it. I talk about my personal passion, why I'm in this business. So I really am driven by that. I take everything, well, I shouldn't say everything. I take it very personal because healthcare is very personal. I like to connect not only with the employers, talk about their budget and their goals, but also at the end, the employees, because it has to work for them too. So that is excellent, Dave. I love that. And, as you said, healthcare isn't broken by accident. It's designed this way. It's the healthcare contract language, that benefits the carriers, not the employers. I remember reviewing an ASA from one of the big carriers, not to mention any names, but basically in a nutshell, it said that you, the employer, have no right to ask the providers or your employees how much they paid, how much they were paid, how much they received. And if you want to ask any of them, you can do it only through us. And I thought, wow, you actually signed this? And so many people don't read this. It's like when you do a software upgrade. Are you sure you want to do this? Nobody reads the terms and conditions, but they should, And, to your point, Dave, this is where a really, really good healthcare broker will review that contract language and just say, hey, look, I don't like this provision. So do you work with the advisors that follow you, that you work with? You have contract language that you go over and teach them about and talk about?
We do, very much so. I mean, that's been a huge part of our work. And frankly, giving you tools to negotiate existing contracts, but really what you need to do is rewrite them from the ground up. And so we have this approach where we've worked with about 400 employers directly in tandem with these Health Rosetta advisors. That's our performance lab. We prove these ideas out. We hear about something working. If we haven't done it before, then we put it through its paces.
Mhm.
After some iteration, then we make it available to all the Health Rosetta advisors and their 10,000 employers that they work with. And
Right.
then, something we'll probably pick up later on is, and then we open source it to the world. And so the TPA contract you talked about is a good example. You can get what we call a TPA field guide that gives you the how-tos, contract language, all this kind of stuff. And so that's what we've been following for several years,
Right.
and has allowed us to have success where there's frankly been a lot of failure in the past.
Yeah, absolutely. That's super, Dave. We're definitely on the same page. We have one client that we took over in 2022 from a large broker. They got a renewal that was $6.2 million, a year, and it was like the per employee per year cost was over 15,000. At that time, the average was about 14. Now it's over 15, of course, as you know. 3 years in a row, we reduced their costs. They were going to have a renewal of 6.18, and last year their expenses were 3.6. So they're actually 35% below the average, national average now, average spending of $10,700 per employee per year. They have large families, 3.4. So I'm really pleased with those results, but it takes a lot of work, Dave. Contract language is some of it, finding the right TPA. And there's a lot of handholding too, because some of these things are scary, and the employees have to, feel comfortable with their health plan as well. So,
Yeah, I mean, that's the thing that if you zoom out, what it is we've tried to do is, yes, the benefit is up here relative to status quo, but the effort's been up here too. And
right.
so our job has been, how do we make it way easier to basically repeatability? How do we make it easier?
Yes.
And then verifiability.
Yes.
Repeatability, verifiability, rinse and repeat. That's
Mhm.
where we've managed to have thousands of successes that versus when we launched this movement, I had written a book. That's kind of what launched it. I had managed to find 5 successes around the country
Mhm.
that had sustained themselves for many years, and now we have thousands. So, we've come
Right.
a long ways. We got a long ways to go. We need tens of
Yeah,
thousands and hundreds of thousands, but it's been
absolutely.
gratifying that people like you, people like me, like it's a grind. There's
It
no
is.
question about
Yeah,
it. But I always say, like, what else is a grind? Being a great musician, a great parent, a great athlete.
absolutely.
Those
Yeah.
are the most rewarding things you do in your life.
Yes.
And so, like, I have no problem, you know, reading contracts. And like, believe me, that's like the last thing I wanted to do coming
Right.
into this. But it's like,
Yeah.
oh my gosh, like, and then of
Yeah.
course working with great attorneys who can really add
Yes.
their expertise to it.
Yeah. I had an episode with Benjamin Jolly a few weeks ago. And he told me about the New Jersey case, the PBM. This is the state of New Jersey. Their state employees, they were going to tender. And then the PBM that they had, when they found out that, the state's going out to tender and they wanted to use their own contract, they said, well, wait a second. You know what? We just found 25 million spare dollars that we can reduce your costs by. Nah, I think we still want our own contract. Oh, wait. Did we say 25? We meant 100 million. I'm sorry. We misspoke. Nah, it sounds great, but, let's just go with our own contract. I think Benjamin told me at the end of the day, they saved like over $1 billion a year. I mean, it was ridiculously crazy. You know, the state of Tennessee, I analyzed their health plan, $2.7 billion of billed claims. And I remember CT scan of the abdomen with and without contrast, the average charges were 635. The high was 19,800. I mean, where is the justification?
Yeah. And at the end of the day, it's not just numbers, it's humans, right?
Yes,
That it's not a bug in our system that there's over 100 million Americans in debt to healthcare. That's a feature
right.
of our system. And that's
Absolutely.
why, one of my favorite quotes is the Buckminster Fuller quote that says, you never change things by fighting the current reality. You create a new model that makes the old obsolete. And,
Yes.
I for those on videos, like, show my camera. Like, did we get these by tweaking landlines and rotary phones? Like, of course not. That's
No.
always the way.
Exactly.
And we have now 70% of the workforce are millennials and Gen Z. Do we think this system is designed for them? You know, it was designed for the greatest generation and boomers when acute conditions were the main issue. The main issue now is chronic disease and mental health. Like, it's kind of obvious that we're overdue for the once every 50 to 70 year shift that happens in healthcare.
Totally. Yeah, absolutely. And I'm glad that you're part of this movement, because you've been a great influence in this world. And, you know, speaking about the 100 million Americans in debt, every minute of every day, a new family declares bankruptcy due to medical debt. Every minute. That's crazy. You know, we're you know, the biggest economy on earth, and healthcare is unaffordable. So it's crazy, and it's got to be, you're right, torn down and rebuilt from scratch. So
I wish that wasn't the case, but it tends to always be the case.
Yeah, I agree, unfortunately. So let's talk a little bit about contract language and what's kind of really draining your language. Data access restrictions. I think that's a big one. Why do carriers hide you as the employer, your own claims data, and how it costs you, and how does that affect you at the end of the day?
Yeah, I mean, one of your examples you gave is you get to see the data. And, you know, I've been in business a long time. I've never seen a business doing great work for their customers that doesn't bury their customers in all the data that shows what an awesome job they're doing.
Right.
So, like, just even if you didn't know anything about healthcare, that's an enormous red flag anytime when somebody says, no, you can't see that stuff. Well, and we found, we had Tufts University did a study of the plan grades. We came up with this idea of grading health plans as a first objective mark of value of that. We have 2,000 to 3,000 of them now. The single most predictive question of the 40 of whether it would be a high performance health plan delivering great outcomes and value was complete unfettered access to their data. Again, following HIPAA guidelines, all
Sure,
that.
of course. Yeah.
When you had that, then you could see, oh, wow, we're spending $10,000 for a drug that we can get for $300. We're paying, you know, $60,000 for a procedure that we can get for $4,000 all in.
Yeah, right.
It sheds the light on that. And also, you start to see the volume, like the case that came out recently with, I think it was Blue Cross Blue Shield of Michigan and TR Yachts. And they basically, there were, you know, when somebody left Michigan, right, they were part of the Blue network and right, you know, theoretically should be getting the Blue prices. Not that they're that great, but but they said, no, we're just going to go with bill charges. Right. And then they would then save, in air quotes, the money and then take 30% of the savings. And another case, this is like my all-time favorite awful story, that was public record. Like, you can go see TML Recovery versus Cigna. The billed charges, I think it was inpatient site case, $996,000. Who knows whether those were all legitimate? Let's put that aside. Cigna marked up the bill to $11 million. Yes, 11.
Wait, from 900,000 and change?
$1 million, 996,000. So they marked it up to 11 million so that they could, quote unquote, save 7 million. And so they got $2.5 million for their so-called savings. Multiplan was their partner in that. They made like 670,000. The provider made 870,000. So they made way more than the provider for the so-called savings. But that's the type of thing that is in these contracts that people are not paying attention to.
Yeah, that's egregious.
By the way, the employer paid $4 million. You add that up, the employer paid $4 million for less than $1 million billed charges.
Okay. Wow. Okay. So and once in a while, when I'm analyzing claims, you know, for an employer, I see a lot of bills are paid at higher than billed charges. And I say, why would you pay more than was billed? You know, I mean, if I send you a bill for whatever service I provide for $100, other than a tip, you know, for a service provider, why would you pay me $300? or 1,000. It's oh wow. That's one of the battles we face, Dave, and that's where we have to get really on top of it. And along that same line, often an employer or a TPA will find maybe a local provider, local health system, local hospital, and they want to steer the employees to their better quality, better value care. How, one of the things I want to talk about is how carriers prevent you from directing employees to higher value, lower cost care. How do they do that?
Yeah, there's these contract terms that are called anti-steerage. And, they treat you like you're cattle or something. And they say, no, Dr. Death, there was a podcast series on that.
Yeah, I remember that. Yeah.
You're prohibited from avoiding Dr. Death because, we don't want that to happen. And there's a whole set of reasons why they have it. Basically, literally prevents you from avoiding Dr. Death. And the fact is, there's a full bell curve of organizations, leapfrog, hospital safety things. There's D and Fs in those hospitals. You don't want to go there, right? No. Unless you're in the business of wanting to pick up hospital acquired infections and sepsis and things like that. Right. You want to stay away. There, conversely, and much more positively, there are outstanding providers.
Yeah.
That's where you want to go. The facilities are great. The surgeons are great. The whole team's great. And, they know what they're doing. They're doing it all the time. And that's where you want to go. Why would you have something that would prevent you from going to the highest quality providers?
Right. And an interesting adjunct to that is I know there are a couple of, and I don't want to misquote because I don't remember which one this is, but a very, very famous, world famous, great hospital is rated an A on cardiac care, but a D on orthopedic care. So just saying, wow, this is one of the best hospitals in the world. I want to go there. Well, if you want to go for heart, absolutely. But if you want to go for maybe orthopedics or something else, it could be the worst place.
Absolutely. I know the exact one you're talking about, and it's one of our greatest successes is steering away from those low, basically. And that's when if you have like a nurse navigator who can kind of understand and explain,
right.
Hey, if you go over here, this is the best surgery facility in Ohio, best surgeons. You're going to need to drive an hour, but you're going to pay exactly zero. Or look at the data here. For that knee procedure, they have all these infections and redos, and you're going to have to deal with these super high deductibles and all that brain damage. Yeah, the choice is obvious. Most people are happily going to drive an hour to pay zero for the best surgery outcome they could get.
Right. Well, Dave, healthcare is personal. We all, in an ideal, perfect world, we'd like to go to the closest hospital for most stuff so our family can visit us, et cetera, et cetera. When we buy other things, TVs, computers, et cetera, we think nothing about driving across town or, maybe even crossing a state line or something to get better quality at a lower cost. But we don't give that much thought into our own healthcare, and largely because the data just isn't there to help us drive those decisions. But you're absolutely right. And I think that's one of the things that can drive this. Transparency in price alone is not enough. And if anything, and I remember you and I discussed this, 10 plus years ago when I did a video where I demonstrated that an experienced surgeon could potentially do a knee replacement, was the example that I used, for $30,000 because he's in and out in no time. He sees a complication. He knows exactly what to do. 25 minutes. So you've got 2 units of OR time, 2 units of anesthesia, and almost zero complications. A less experienced one might take an hour and a half for the same procedure or two. So more OR time, more anesthesia time, and probably a night or two in the hospital, chances of complications. So if you show people just the price and you say, look, you're out of pocket, your deductible is $5,000, whichever one you go to, this one's 30,000, this one's a 90, most people would take the 90, because they think that price is a proxy for quality when it really isn't.
Yeah, I mean, it is confusing for people, right? You spend more money on a car or a house, usually you get a nicer car or house, right?
Yeah.
And it's just not that way in healthcare. If there's any correlation, it's reverse.
Yes, absolutely. And we now spend more on healthcare than we do on housing or food, which is crazy. So let's talk a little bit about some of the hidden fees and revenue streams that, for example, the PBM pharmacy benefit rebate shell that most employers never see.
Yeah. Well, and it's, it's a whack-a-mole game there. Like there's been some scrutiny on rebates. And so then there's like, oh yeah, you get all the rebates, but then they don't mention they have this offshore group purchasing organization that's actually getting all this other revenue, right? So you really need to follow the full chain of custody on those dollars. So yeah, there's this whole rebate game. There's been a little bit of a crackdown, but it just goes from one area to another. And you see, we were talking about, brokers and advisors, and we see very regularly. In fact, you look at the recent class action suits that have come out, all kinds of breakdown of the shenanigans in the pharmacy spending, including these consultants who, for the privilege of they're already getting paid by these PBMs to pull them into these agreements. They will then add $7, $13, $14 to literally every prescription goes to the benefits consultant, and their firm. Yeah. And so it's not unusual where the manufacturer, the pharma manufacturer, right, they're not exactly in the poorhouse, are actually making less money than the PBMs because of, we've seen somewhere, I think now it's up to about 50 different revenue streams that we've seen pharmacies create for themselves. If you look at the whole, particularly you have the vertical integration, these offshore GPOs, I mean, it can make your head spin. Yeah. That's why you have to seize control of the way you purchase and the way you define things. There's one of the ways that they do a lot of arbitrage is definition of what's a specialty drug and things like average wholesale price, which is, something that means, any wild ass price or ain't what's paid. It's just a fiction, but it's one where people get caught up in the rebate game or they get caught up in the discount game. And it's like, go back to that car. Ralph, I got a car to sell you. I'm going to sell you it for 99% off. Mm-hmm. Will you take that deal?
Right.
In healthcare, a lot of people would. Well, the starting price was $10 million, right? But I gave you 99% off. Yeah. So isn't that a great deal?
Exactly. A lot of people are fooled by that. You're right. I had a case where large employer, over 25,000 members, they were spending about over 70 million a year just on their drug plan. I think it was about $3,000 per employee per year. It was really, really outrageous, and it was just because of these kinds of things, and it's just that shell game that they don't see all the time. So
that's one of the things we're working on. As I mentioned, we go through battle test these things, and once we feel confident enough, we battle test enough, then we open source it. And the next one that's going to get released at Rosetta Fest is the PBM field guide, because it's such a high demand area. The TPA was really important, obviously. And those are the two, I'd say TPA, PBM, hospital contract. Those are the three most important contracts you can scrutinize.
Absolutely. Well, I would love to have you on for another episode to talk just about that, because I think we're getting close to our time. So if you could join me for another episode, that would be great. Dave, thanks for cutting through the noise and showing the employers what's really possible when they take control. But before we sign off, if folks want to dig deeper, follow your work, or join the open source movement, which we're going to talk about next episode, where should they start?
Yeah, for me personally, just Google my name, find me on LinkedIn. I'm at Chase Dave on just about everything, but pretty easy to find there. As an organization, healthrosetta.org we actually have two entities. That's a public benefit corporation, and then we have Nautilus Health Institute, which we'll talk about in the next episode, which is what holds the open source resources. So those are good places to start, and I can happy to point you towards other things if that doesn't answer the question.
Yep, absolutely. We'll definitely talk about that on the next episode. So to everyone listening, healthcare it really isn't a mystery. It's baked into the system. And when you know where to look and what language to look at, you keep money where it belongs in your business and with your people. I'm Ralph Weber, the Benefit Whisperer, and thank you for joining Dave Chase and I today. If today's conversation gave you something you can use, share it with a colleague, like it, subscribe, and reach out anytime you want, Ralph at thebenefitwhisperer.com, or call us at 832-924-3330. Again, Dave, thank you for being here for today.
Yeah, my pleasure.